Hey, good afternoon, everybody. On behalf of my colleagues at the National Center for Disaster Medicine and Public Health, or NCDMPH for short, welcome to today's webinar entitled The Well-Being of Underserved Populations During COVID-19 Crisis. My name is Norma Quintanilla. I'm the project assistant at NCDMPH and your moderator this afternoon. For your awareness, this webinar is being recorded, and the recording and transcript will be available on our website at usuhs.edu/ncdmph. In June, we discussed how COVID-19 impacts the human performance and mental health of healthcare workers. If you were unable to attend, you can find a recording of the webinar on our NCDMPH YouTube channel. As our nation continues to grapple with the pandemic on many levels, the incidence of mental health has increased dramatically due to COVID-19. How you respond to stress during the outbreak can depend on your background, your social support, your financial situation, your health and emotional background, the community you live in, and many other factors. This afternoon, we'll focus on how COVID-19 impacts the well-being of underserved populations, more specifically in African Americans, Latinx, indigenous populations, which have long experienced disparity in access to care. We are pleased to hear from trusted experts in public health, behavioral health, social work, and indigenous science. We have an extraordinary lineup prepared for you this afternoon. As a dynamic duo, Liz Wolfe and Naomi Flores will lead us in our discussion. Then we'll hear from Jacqueline Patterson. And last but not least, we'll hear from Paulette Blanchard. Today's webinar has been approved for 1 hour continuing education credits for CME and CNE. Please note that if you want continuing education credit, you should have registered through Eventbrite with your first and last name. All participants today will receive an email within a few days from cpd@confex.com with information on claiming credits. All online evaluations must be submitted by October 1st, 2020 to receive credit. None of our speakers have any relevant financial relationship to disclose. We will have a few minutes near the end for Q&A. In the meantime, please use the chat feature to enter your questions. Please indicate the speaker you wish to direct your questions to. If at the conclusion of the webinar your question is unanswered, you can forward it to ncdmph-event@usuhs.edu. Before we dive into the conversation, I want to give you a sense of who we are at the National Center for Disaster Medicine and Public Health. NCDMPH is an interagency center established under a presidential directive. Our mission is to improve our nation's disaster health readiness through education and science. Recently, NCDMPH released the second edition Curriculum Recommendations for Disaster Health Professionals. This co-sponsored curriculum is a resource tool for educators and trainers working with health professionals and others concerned with the psychosocial consequences of extreme events. It is now my pleasure to introduce our first speaker, Liz Wolfe. Liz is the Director of Clinical Services for Behavioral Health at Mary Center, a federally qualified healthcare center located in Washington, D.C. and Maryland. Liz has worked for Mary Center since 2013 and previously worked for other community-based client-serving nonprofits in Washington, D.C. Liz is a clinical social worker by training and earned her Master's of Social Work from Smith College School for Social Work. Liz will be presenting alongside Naomi Flores. Naomi is an integrated behavioral health IBH therapist at Mary Center. She has worked with the Latinx community for the past 6 years. Through her unique role as an IBH therapist, Naomi provides short-term episodes of mental health care. Naomi obtained her Master's of Social Work degree from the University of Maryland School of Social Work. Liz and Naomi, welcome, and thank you for kickstarting the discussion. Liz, over to you.
Great, thank you, Norma. I am so happy to be here. My name's Liz Wolf. Again, I work at Mary Center, and I thought that this afternoon I could just give you a little bit of background information about Mary Center, who we are and who we serve, and share a little bit about how COVID has impacted our patient population before turning it over to Noemi, who works day in and day out with our patients directly, and can share a little bit more about what she's seeing on the ground with our patients, what she's seeing and hearing. So in this slide, you have a map of DC and our Maryland and Virginia suburbs, and the areas in dark blue are where Mary Center locations are located. So Mary Center has 8 sites in DC and Maryland. We've been around since 1988. We have over 700 staff. We provide primary care, OB and prenatal care, dental care. We offer a full range of outpatient behavioral health services. Our behavioral health team is about 85 staff. And Mary Center also operates with what we call a social change model, which really takes a hard look at the social determinants of health and recognizes that you can't treat someone's health problems in isolation from all of the other aspects of their well-being that impact quality of life. So with that in mind, Mary Center offers a range of different social services. We have 2 senior wellness centers. We have a public charter school co-located at 3 of our health centers. We have a teen program, domestic violence support programming, case management, and a lot of other social services that really seek to treat all aspects of well-being, not just healthcare, in order to get better health outcomes. So next slide, please. So this slide just gives you a little bit of background information about who we serve. So in 2019, we served over 55,000 participants. As you can see in the first pie chart, the vast majority of our participants are on public health insurance or are uninsured. And then by race and ethnicity, 70% of our participants identify as Latinx or Hispanic, 44% identify as white, 16% identify as Black or African American, and then 25% aren't reporting their race. So we sort of assume that of the 70% who identify as Latinx or Hispanic by ethnicity, some are then identifying as white by race or Black or Afro-Latino or aren't reporting their race. So that's kind of who we serve generally. And the next slide. So this slide shows the rates of COVID-19 among our participants. So between March and July, we had 898 patients at Mary Center test positive for COVID, and 92% of those identify as Latino or Hispanic. So this is reflective of a broader trend in the DC, Maryland, Virginia region, where we're seeing a much harder, we're seeing Latin communities much harder hit by this virus than other communities. So some of the statistics are really staggering. In DC, Latino residents make up 11% of the population, but a quarter of COVID cases. And then in Montgomery County, Maryland, one of our suburbs, the statistic is even more staggering. In the month of June, Latino residents accounted for 73% of all new infections, in spite of making up only 20% of the population. So 73% of new infections, despite only being 20% of the population. So we're seeing the Latinx community very hard hit. And one of the likely reasons for that, I'm sure this reflects trends nationwide, is that the people who identify as Latino tend to be overrepresented in so-called essential occupations like cleaning, caregiving, construction work. And so they're continuing to work through the pandemic. And then also are more likely to live in households with multiple roommates or in multi-generational households where social distancing and quarantining is really difficult or impossible. So we've seen this community really hard hit in DC, and we've seen that borne out in our positivity rates among our patients. And then in this graph, you can kind of see that the test positivity rate has declined over time, which is consistent with trends in DC. We had a peak in April and May, and it's kind of started to creep up again as DC has reopened. So from there, I will turn things over to Noemi, who can share a little bit more about what she's seeing as a behavioral health therapist on our team, what she's hearing directly from her patients.
Hi, everyone. As Norma introduced me, my name is Noemi. I am an integrated behavioral health therapist at Mary Center, and I have been with Mary Center for the past 3 years, about 4. Prior to that, I was an intern. So I'm happy to be here with you guys as well to just briefly share some knowledge and what I've seen throughout this pandemic. So I wanted to briefly just describe what is integrated behavioral health. So the IBH staff serve triage function to assess patients with behavioral health symptoms and make treatment recommendations based on presenting concerns, readiness to engage in treatment, and appropriate level of care. So triage is based on assessment score. So some brief screens that we tend to use are the PHQ-9, the GAD-7, the Edinburgh, and the CAGE-8, and these help us to assess the level of acuity. So triage is based on assessment scores, protective and risk factors, and we also use our clinical judgment. IBH staff can connect patients to other programs and levels of care within Mary Center and outside of Mary Center. So we tend to connect them to long-term psychotherapy, school-based mental health programs, early childhood behavioral health programs, community resources, medication-assisted treatment teams, psychiatry, home visiting groups, etc. Next. So I just wanted to briefly discuss what are some common presenting concerns that we've been noticing, myself and other IBH staff and therapists at Mary Center. Some common presenting concerns during COVID-19 in the Latinx community. A lot of the factors that are contributing to these concerns we've noticed have been financial barriers, medical barriers that have contributed to depression symptoms, anxiety, grief and loss, trauma, and PTSD. So with depression, we use the PHQ-9, which is again a brief screen to help us determine the level of acuity. With depression, we've noticed low mood, low energy, often somatic manifestation of symptoms such as headache, body pain, insomnia due to inability to live normal routine, unable to go to work, and due to isolation. We've also noticed anxiety symptoms, so high levels of anxiety, panic about contracting COVID, unemployment, financial situations, rent, ineligibility to qualify for government assistance programs, etc. So we have noticed that these financial barriers and the inability to qualify for government assistance programs, a lot of places of employment shutting down temporarily or some permanently, such as hotel positions, house cleaning jobs, restaurants. This has caused a lot of anxiety and depression in the Latinx community, predominantly because the population that we serve at Mary Center, as far as the Latinx community, are undocumented, and that obviously serves as a barrier for many to being able to qualify for unemployment benefits for government assistance programs. So that has obviously produced a lot of anxiety and depression in the Latinx community. There also has been a difficulty to differentiate between COVID and anxiety and panic attack symptoms because some symptoms may be similar, such as difficulty in breathing or tightness or pain in your chest. There has been that difficulty to differentiate if it's COVID or anxiety and panic attack symptoms. And I think it also has made us vulnerable as therapists because we don't have all the answers. And then in addition, we've seen anxiety reactions that may appear as OCD-like symptoms. So there's been a lot of frequent hand washing, intrusive thoughts, obsessions, etc. So it also can be clinically hard for us to diagnose if it's OCD or if it's just an anxiety reaction due to the pandemic we are living in now. In addition, we've noticed grief and loss, so grief and loss of former normal life. we've had a lot of patients that are having a hard time adjusting to the new normal. A lot are missing their life how it was before COVID, being able to go out without having to use a mask, not having to practice social distancing, being able to socialize freely without worrying if you're going to become infected with COVID. In addition to grief and loss of actual loved ones due to the virus. We've also noticed trauma and PTSD symptoms that includes nightmares, flashbacks, intrusive thoughts, hypervigilance among those who have been diagnosed with COVID, specifically those who have had to been hospitalized due to COVID. So these are some of the things that again, we have noticed are some presenting concerns during COVID-19 in the Latinx community.
Okay, great. Thank you. All right, so let's turn to our next speaker. Okay. Jacqueline Patterson. Jacqueline Patterson is the Senior Director of the NAACP Environmental and Climate Justice Program. Since 2007, she has served as the coordinator and co-founder of Women of Color United. Previously, she served as Assistant Vice President of HIV and AIDS programs for IMA World Health in 23 countries. Jackie holds a master's degree in social work from the University of Maryland and a master's degree in public health from Johns Hopkins University. She currently serves on the steering committee for Interfaith Moral Action on Climate, the advisory board for Center for Earth Ethics, as well as on the boards of directors for the Institute of the Black World, the Hive, Gender and Climate Justice Fund, the American Society of Adaptation Professionals, Greenpeace, Bill Anderson Fund, People's Solar Energy Fund, and the National Black Worker Centers Project. Jackie, thank you for joining us. I'll turn it over to you. I'll stop sharing my slides.
Thank you so much. It's a pleasure to be here with you all and to have this conversation. Hopefully everyone can see my slides, and I will.
Yes.
Yeah, great. Start slideshow. And here we go. So I will be talking about taking a couple of steps back from my co-panelists and talking about the systemic inequities that have led us to where we are in terms of the very well described disproportionate impacts on the communities that my co-panelist serves. And so they went into the depth about the ways that these impacts live out. And I will be talking a little bit about how the system has led folks to where they are and who is disproportionately impacted, and some of the big picture in terms of how. So whether we're talking, we often talk about the historical context of these systemic underpinnings, the rampant extraction and exploitation of humans and natural resources, and the policies that have been institutionalized to advantage a few, a wealthy few, corporate few, at the expense of many others. And so we've seen it play out in our trade policies, our manufacturing policies, our finance and labor policies, our health policies. And so the way those systems have been designed that have prioritized profits and property over the health and well-being of and human rights of people is what has gotten us to where we are today. There's a quote from Martin Luther King: "I never intend to adjust myself to economic conditions that will give take necessities from the many to give luxuries to the few." And that's the socio-political and economic context in which COVID-19 landed, and therefore left a whole swath of the population disproportionately vulnerable to its impacts, and certainly to further to the economic impacts that have arisen as a result of the pandemic. So some of the systemic drivers of these disparities include racism, xenophobia, classism, or poverty, and some of the ways it plays out include policies around redlining and the modern day gentrification and displacement, the corporatocracy and privatization, how corporations are are tied to our democracy in a way that means that our policies aren't what they should be. The criminalization of poverty, the insufficient regulatory system that results in that unholy marriage, and so forth and so on. And some of the populations that we see at risk, including the populations that my co-panelists were talking about, include BIPOC populations, children, incarcerated persons, and so forth. And that's what I'll quickly go through. So whether it's BIPOC populations and the ways that people have been experiencing racism in terms of the mistrust and fear around COVID-19 and how that's played out into anti-Asian racism and otherwise. We've seen too many of these headlines in terms of how that actually plays out. Or it's the ways that these certain populations, because of historic racism and anti-indigenous actions, have resulted in certain communities being disproportionately vulnerable to the impacts, whether it's Native American or indigenous communities, Latino communities, or African American communities, all of which we've seen having higher rates of of COVID-19. We also have the disproportionate vulnerability of undocumented persons and how some of the policies have resulted in exacerbating those conditions, whether it's people being confined in detention centers or people having a fear for engaging with the health system and therefore perhaps going undiagnosed, and then because of the lack of economic opportunities around among the populations, ending up co-residing with folks, and therefore we're seeing more proliferation of COVID-19. Environmental justice communities, we've seen where air pollution is linked to severe cases of COVID-19, whether it's because the lungs of people who live in environmental justice communities are already negatively impacted, as well as other parts of our health, individual health systems. And so when we're already vulnerable because of those pre-existing conditions, then we're more likely to experience the negative effects of COVID-19 because of those pre-existing physical vulnerabilities. And then on top of it all, a study by Harvard University said that COVID-19, there's some evidence that finds that COVID-19 actually rides on PM 2.5 particulate matter pollution, which again is disproportionately located in communities of color and low-income communities, African American communities. 71% of African American communities are in violation of federal air pollution standards. As an example, we're more likely to live next to incinerators or oil refineries or coal-fired power plants or near roadway air pollution, and all of those have a proliferation of PM 2.5 pollution. And even indoor pollution, whether it's the paint or the quality of other types of things in the home, or it's these household products that are now being used extensively, because of COVID-19 and the excessive cleaning, the excessive cleaning that we're doing. Then we are seeing the ways that that people are coming in contact with toxic fumes and so forth in the household, which again impacts the lungs, but also even worse in terms of the level of toxicity in some of these underregulated products. And that again goes back to the tie between groups like the American Chemical Association and their lobby, which keeps down the list of items that are considered to be toxic according to the toxic release inventory and so forth. So all of that is interconnected with the types of toxicity we find in our homes. And on top of it all, we have these products that are the most popular products that are on the EPA's list, whether it's Lysol, Clorox, Purell, are in such short supply. And so when we have communities that are already in, whether it's food insecure, they're less likely to have the types of stores that would have these types of products in the first place. But then we all know, even when I go out on the weekends to try to do my shopping, I have to go to 5 different stores before I can find, one of these these cleaning products that work. But I have the luxury of my Subaru Crosstrek, and so most of the people that we're talking about do not. So these are the ways that we have compounded risk and so forth for folks. Incarcerated persons, we've all heard the stories of the disproportionate impacts there from people being incarcerated. This is actually supposed to be in the Immigrant Rights Center in terms of the Immigrant Rights section in terms of people not having access to health care, people with special health needs, whether it's older persons, immunocompromised persons, or others. Again, we all know the disproportionate impacts there. And people with housing insecurity, whether they had housing insecurity before, or whether they're homeless before and now and experiencing more exposure there, or as a result of the economic crisis, we're seeing more and more people, more and more evictions and so forth. And so we see an increase in homelessness, which again puts people in harm's way. People with energy insecurity. We put out this report a couple of years ago, Lights Out in the Cold, Reforming Utility Shutoff Policies as if Human Rights Matter. There's been some strides made around addressing the insecurity, but we have so much more to do to really see equal rights as it relates to access to electricity, heating, cooling, and so forth without pause in this time. So again, it's another example of criminalization of poverty, and some people are actually paying the price with their very lives, whether they have their electricity cut off and they use candles. We know candles is one of the top leading causes of house fires, or they have their heating cut off and they use space heaters, and we know space heaters are not one of the top causes. So these are the ways that people are in harm's way. Rural communities, because we know so many of the resources end up in urban areas. So this is the next frontier in terms of disproportionate impact. Women as well, whether it's because of women typically in caretaking roles, which results in more exposure, or unfortunately what we're hearing in terms of the increase in domestic violence as a result of COVID-19, as we've seen with past disasters, whether it's Hurricane Katrina or the earthquake in Gujarat. Place after place, we see an increase in violence against women in the context of disasters, and this is happening yet again with the COVID-19 pandemic. Gig economy workers, underemployed persons, essential workers, avoiding the COVID-19 for these workers is a luxury that many cannot afford. And then we have, again, the unholy tie with the between corporatocracy and our political system, with companies actually paying groups like ALEC to fight back against sick leave and other types of leave that are so critical during this time, so that people are not in harm's way. People experiencing food insecurity. We've all seen the long lines on TV and so forth, or we might have even stood in some of these lines ourselves, and hopefully we have that level of representation on these calls to ensure that we really are engaging people who are most impacted on the front lines. So these, of course, is more exacerbated, and the interesting tie between food insecurity, it's a result, the increased food insecurity is a result of COVID-19 and the economic crisis, but the food insecurity that existed before is it resulted in the proliferation of COVID-19 in certain communities, where we're talking about historic redlining and modern day gentrification and displacement. Means that there's some communities that are more likely to have a corner store than they're likely to have a grocery store, much less a farmer's market, which again means that they're more likely to be in harm's way in terms of diabetes, heart disease, and hypertension and so forth that lead to COVID-19. And we've seen that, so and then with communities with under-resourced schools are in trouble now, as we start to see people going back to school, and the extent to which there's a possibility of remote learning. And then taking that more broadly, broadband access in general is something that is critical, whether we're looking for a job or looking for where the nearest food bank is, or looking for any of the other resources that we need to survive in these dire times. So I only have about a minute left, and I have like 50 slides, but I think you'll see, I think you'll get a copy of these somehow. But I'll just kind of end with a couple of more in terms of the last impact I'll say is that on our very democracy. You've heard this conversation about the post office and voting by mail and so forth, and so this is a critical piece of impact. So when we talk about systemic exacerbation, it's the ways that corporate control happens over our democracy, the ways that whether it's fossil fuel companies or others are manipulating our democracy, and how that plays out in terms of the types of policies that we have that are either not protecting us or protecting corporate interests at our very expense. And so as we talk about how to turn things around in my last 30 seconds here, stopgap measures, including providing immediate relief, whether it's unemployment benefits, public assistance, moratorium on shutoffs, reversing rollbacks of environmental protections, increasing regulations, monitoring and enforcement, housing security for all, food assistance, testing and healthcare for all. And then there's the longer term systems change that we need, because we wrote the 10 equity implications document on March 10th. And because we were able to predict what would happen, you know, even when they were just talking about the outbreak in New York and Washington State, it was clear what was going to happen, because this is what happens around every disaster, because it's the same communities that are disproportionately vulnerable. So in order for us to not find ourselves at this juncture time and time again, we have to change the system. So I will leave off the remaining 20 slides and turn it over to our moderator again. Thank you so much.
Great, thank you. All right, so I can share my slides with everybody. Okay, wonderful. Thank you, Jackie. Okay, now let's turn to our final speaker, Paulette Blanchard. Paulette is currently a PhD candidate in the Department of Geography at the University of Kansas, and 2008-2020 UCAR Diversity and Inclusion Fellow. Her work addresses the challenges and opportunities that Indigenous peoples face in relation to climate change and climate justice. She incorporates Indigenous feminist methodologies, ethics, protocols, and philosophies into her geographic framework. She has interest in how and why science education influences Native students to stay or leave academic and science spaces, as well as how mentoring contributes to their success. Paulette holds a Master's of Arts in Geography from the University of Oklahoma and a Bachelor's of Arts in Indigenous American Indian Studies from Haskell Indian Nations University. She is absentee Shawnee and Kickapoo. Paulette, it's a pleasure to have you. Please take it away.
Yahweh. Haki Hawesi Lasamamo. My name is Paulette Blanchard. I'm a citizen of the absentee Shawnee tribe of Oklahoma, Kickapoo descent, as well as being French, Scottish, Irish, Dutch, English, and who knows what else, you know. But I do reside in the traditional homelands here in central Oklahoma of originally the Caddo, Kiowa, Comanche, Wichita, and Osage people who originally lived in this region. I now reside within the jurisdiction and the reservation boundaries, I guess, of the Citizen Potawatomi and absentee Shawnee combined lands in central Oklahoma here. I'm part of the Converge COVID-19 Working Group for Public Health and Social Science Research Project, and our working group name is Indigenous and Earth Science Knowledges and Practices in COVID-19. This paper is being written to advance convergence-oriented research in the hazards and disaster fields, and it highlights area where additional research can contribute to the knowledge to the response and to the recovery of the pandemic and other disasters yet to come. So the working group description is COVID-19 is having specific and devastating impacts, yet is already spurring resilience among Indigenous populations due to unique histories, cultures, geographies, and capacities. The Working Group on Indigenous and Earth Science Knowledge and Practices in Response to COVID-19 foregrounded Indigenous perspectives in defining research questions for potential intercultural collaborations between Indigenous and Earth Sciences to drive urgent, culturally relevant, and appropriate responses to COVID-19. The working group included intercultural, intergenerational, and interdisciplinary representatives from the Rising Voices Center for Indigenous and Earth Sciences, a nationwide network of over 650 scientists, educators, students, and community leaders and organizers. To identify priority research areas and emergent questions, the working group hosted a webinar discussion and fielded questionnaires with the Rising Voices community, as well as utilized their own perspectives and expertise. Next slide, please. The priority research topics and specific research questions are as follows. All communities are experiencing the effects from coronavirus, yet Indigenous people have experienced exacerbation of issues that stem from the government shutdown and many other factors. For Indigenous cultures, the relationship to place is paramount. Turning to the resilience and wisdom of our Indigenous ancestors continues to be a strategy used during all manners of disaster. The following topics were identified by the Working Group on Indigenous and Earth Science knowledges and practices in response to COVID-19 through community discussions and analysis of the community questionnaire. 53 people responded to the questionnaires, which investigated topics including, we asked where the respondents lived, we asked what their challenges and the challenges the respondents and or their communities were experiencing that were making the impacts of COVID worse or hampering the responses, what has gone well, and what Indigenous knowledges and practices might be helpful. Any observations that respondents have made or heard about the coronavirus and COVID-19 related to climate and or environmental factors, and what questions respondents have about the coronavirus and COVID-19 related to climate or other environmental factors. The priority research topic and emerging questions throw into stark relief the disparaging differences between Indigenous people and non-Indigenous people. They also encapsulate positive solutions in dealing with a worldwide outbreak by showing how to revert to traditional practices in times of need. The result from the questionnaire highlights 4 dynamics that Indigenous people are facing in present day to the coronavirus outbreak, including several emerging questions. Next slide, please. These themes include food security and safety, pre-existing conditions, turning to resilience and wisdom, and then emerging questions at the nexus of Indigenous wisdom, knowledge, and earth sciences. When it comes to food security, it's a top concern due to the government not allowing access to traditional lands and sites where traditional foods can be found. This includes hunting, fishing, and foraging. Traditional foods can be obtained through hunting, gathering, hiking, fishing in what some people would call the mountains or backcountry, but what many indigenous and traditional people call home. These foods connect to the well-being of a person spiritually, mentally, and physically, and their absence is detrimental on health when not obtainable. And some of these foods go beyond foods, they're medicines. We look at food as medicine. Medicine is sacred. And so many of these foods we have these long existing relationships with, and try to nurture these relationships with reciprocity, caring for the plant, knowing that these plants, animals, and other things care for us. Another element to food security highlights the tribes and nations that live in food deserts or deserts and other remote locations, and their access to traditional substance is cut off. The only other option is to drive hours to grocery stores. Because of stay-at-home and quarantine orders, however, this option is often forbidden, or else we close our borders so that not only we don't go out, but we don't want people coming in to bring in the virus, germs, bacteria, and other things. We have a long history with it, with the colonizers and the diseases and illnesses that they've brought. This dynamic puts family at risks for unsafe and unhealthy eating practices, and some families are risking their health by eating what is obtained, even if it's out of sync with the food, when the food is traditionally consumed, like when eating a food like a shellfish out of season can create paralytic shellfish poisoning. Another issue is, is water. Some tribes don't have access to electricity or water, so even growing a garden becomes a challenge. Another issue is the pre-existing conditions. Many different disparities that Indigenous people endure during their daily lives are underlined and exacerbated at times of emergency, such as with the coronavirus. Many of the results from the questionnaire highlighted concerns such as the rate of poverty as seen through housing insecurity and limited resources that affect education, health, and finance. The lack of not having jobs leads to a profound lasting effect on families and their individual members. We have an 80% unemployment rate on good years in some areas of tribal lands. Throughout the questionnaire, the need to raise attention to the continued bias and racism against Native peoples sets a tone for the distrust of the government, thereby not taking the directives of stay at home seriously. What comes out of the discussion is the need to have reliable information and communication channels, which is challenging during physical isolation and the lack of internet and computer access for many tribal members. We also have some of the highest rates of cancer, diabetes, heart disease, suicide, and more Superfund sites on our homelands than suffering from environmental racism. We also lack critical infrastructure. Another challenge is that we have multiple generations living in one home, so social distancing is impossible, if not, is difficult, if not impossible. And then we have cultural practices of funerals and ceremonies and prayer meetings and so on and so forth that put us at risk even further, because we're not the only ones suffering with some of these challenges of prayer meetings and funerals and stuff, but these are huge impacts on our culture. So turning to resilience and wisdom, the common denominator throughout the questionnaire results highlighted families navigating back to cultural and traditional practices. This finding highlights cultural practices of Indigenous people that displays the entire family unit living together. These multi-family, multi-generational homes of more than 10 members makes physical distancing difficult. Isolation and or living alone is not common and strays from the philosophy of community over individual for Indigenous peoples. The physical distancing hinders people's practices by not having family members together, much less during times of pandemic. Resilience and wisdom is found in the family unit. Together, a focused relationship on land and place occurs simultaneously. Turning to the resilience and wisdom of ancestors for strategies used during similar events allows Indigenous people in modern times to become resilient based upon the knowledges from their ancestors. There are more people turning to traditional practices in medicine, food sources, gardening, and farming practices. In unity with the family and community, spaces have opened in which the community networks and aides provide meals to youth, elders, and members that do not know where their next meal will come from. The need to farm and garden appears to be the most common response to food security for most families. Some of the emerging questions are the questionnaire resulted in an array of answers that helps to define research questions for potential intercultural collaborations between Indigenous and earth sciences to drive urgent, culturally relevant, and appropriate responses to COVID-19. The following questions are the main ideas that come out of the questionnaire for possible future projects. What role does temperature, humidity play in increasing or decreasing the spread of coronavirus? What role do high levels of air pollution and air particulates play in spreading the coronavirus? As climate and temperature changes, how does this effect expose us to new viruses? How can traditional practices such as not eating certain animals or not disturbing soil in certain places with traditional place names that may include related information prevent virus and other illness transmissions to humans? And one of the things that came up later on that didn't come up early on was the effects of physical, mental, spiritual, and cultural health. Some people feel that these issues are continuations of genocide. We are suffering high rates. We've always had anxiety, depression, and from cultural and historical and generational traumas, but these things seem increased recently through COVID from the stresses, as well as our suicide rates are increasing, not just in Native American communities and Alaska Native, but also in Indigenous Hawaiians. Next slide, please. By valuing Indigenous observations, knowledge, and wisdom, and practices equally within our sciences, this work contributes to decolonizing our sciences, disaster management, and public health. Further, it works to mitigate the particular threats and impacts that Indigenous communities and populations face from COVID-19. Doing so addresses injustices in earth sciences and disaster management and in the disproportionately adverse impacts of COVID-19 on Indigenous communities. These different approaches occur because the different worldviews that come from being an Indigenous person. A collective, co-informed understanding of these concerns and themes allows for different perspectives and therefore different solutions based on ancestral and contemporary knowledges. Ethical research to address the impacts, whether of COVID-19, climate change, or other disasters with Indigenous populations, must be driven by Indigenous communities and engage Indigenous partners at all steps of the process and proceed only when free and prior with free, prior, and informed consent. Methodologically, research in this vein must begin with the approval from IRB institutional review boards, both academically and tribally, and only once approval is granted. So go on to utilize indigenous methodologies that value relationships of trust and reciprocity. Next slide, please. So in talking about the inequity for indigenous peoples, and it comes back to a lot of it to the dispossession of our lands. Our most valuable, needed, and important resource: land, water, sovereignty, access to food, and the ability to grow healthy, safe foods in a free, way. I mean, so beings that indigenous people have a different relationship with the federal government, as well as the agencies tasked to work with us under the federal plenary power of the United States government. We are quasi-sovereign. We're not as sovereign as people think. We're poor people. Not all tribes are successful with their casinos, and when COVID happens, the casinos aren't successful either. So it's important that we realize that indigenous populations, Native American peoples, Alaskan Hawaiians, indigenous Hawaiians, and other indigenous people who come here, come with their own culture, identity, and needs that are unique and have a unique history. So the contributors I'd like to recognize here are from different cultural groups, both Native and non, and I will stop there. Yahweh.
Great, wonderful. Thank you so much, presenters. Those were fantastic talks. So now let's go to questions, to Q&A. I think I jumped slide here. Okay. As a reminder, if you have questions that we unfortunately due to time can't answer, you can send them to ncdmph-event@usuhs.edu. So now I'll hand it over to my colleague, Condra Strauss-Riggs, who will help us in this segment.
Excellent. Thank you so much, Norma. I'm Condra Strauss-Riggs, Education Director at the National Center for Disaster Medicine and Public Health. And I'm so pleased that Norma Quintanilla put this session together for us. And it has just been fabulous to hear from all of you. And it is a lot of information, as some people were commenting in the chat, to absorb. And it's just fantastic to get your perspectives. I know that mainly people so far have been asking for the slides and for copies of the presentation. So the recording will be available. And I think slides as presenters allow. So I have a couple of questions just to kick us off here in the Q&A portion. For Naomi and Liz, I'm wondering about the sort of social supports that your community might be leaning on in this time when so many, obviously, of our in-person activities are curtailed. It's just something I've been thinking about and wondered what you all are seeing in your community that you serve.
So far, what I've seen, a lot have been relying on their faith. So thankfully, while during the quarantine of this pandemic, during the first 2 to 3 months, churches were closed, but there were a lot of virtual online services of worship. A lot of online or virtual like prayer meetings. So a lot, thankfully, were able to attend to that. And that was like a big social support for a lot of the Latinx community, a lot of my clients during that time.
Yeah, I can add to that in our behavioral health department, we used to see people, the majority of the bulk of the services that we're providing are therapy, psychotherapy for people. And when the pandemic happened, we had to transition all of that really quickly to telehealth. That we haven't offered any in-person therapy services in months now. And we really saw huge disparities in people having access to technology or ability to use technology, people not having smartphones or not having a laptop, or like maybe they have one laptop for the whole household and their kid is using it to do remote learning. And so they can't engage in a video chat like that we were offering. So we ended up, there's been a lot of advocacy in DC, at least, to ensure that all of the public insurances allow reimbursement of telephone services so that people can at least continue with their mental health care by phone, which is better. I mean, it's not as good as doing a video chat, obviously, but it's better than nothing. So that's one of the ways that we've seen that this disparity play out as far as like how people are receiving support for mental health. That's been one of the challenges. But I think it's been going okay. I think that like generally people are still pretty engaged in their mental health care. That's what I've been hearing from most therapists, is that they have very few clients who've like totally dropped out of care, that people are turning to their therapist more for support, even if it's just a weekly phone call instead of like an in-person therapy visit like they used to have.
Thank you so much to both of you. You also ended up addressing Gretchen Gates' question about behavioral health interventions. So that's excellent. So leaning on phone sometimes over video call is a great one. So we have Blanca Flor Jimenez is asking, are there any task forces working on finding or developing solutions to these health disparities in low-income communities affected by COVID? And this is open to any of our presenters.
In Native communities, there are actually quite a few. Not only do I work with the University Corporation for Atmospheric Research and the National Center for Atmospheric Research as a graduate student, but I also work with many other groups, the Rising Voices group, it's part of UCAR, as well as many other Indigenous Peoples Climate Change Working Group. And there are lots of them. Indigenous people are working together and with reaching out to other minority groups to try to find and share solutions. We're using both traditional knowledge from our experiences historically with prior diseases. Many of you might recall that many of Indigenous people were murdered through genocide with intentional germ warfare with smallpox, but we also died from the common cold and from flus. They say between 70 and 90% of our population were eradicated prior to even contact sometime because of the way viruses can spread and so quickly. And this is not, our first experience. And we all know one thing, there's a running joke that sure, you can trust the government, just ask an Indian, because everybody should really be informed that Indians have been abused more by the government than any population. And you can assess how the general population is treated by how they treat their most sensitive and vulnerable, which is often Indigenous people, because we're the invisible group. So yeah, there are lots of different task forces and groups trying to address these from multiple directions in many groups, because clearly the government at both local, state, federal, especially federal, is not addressing it. So we have to be cognizant of that and address it ourselves.
Yeah. That's great, thank you. And we see a colleague chiming in on the chat talking about the CDC Foundation that has just stood up a COVID-19 surge staff around tribal epidemiological centers. So that's fantastic. Thank you, Paulette. Sheila James is asking, looking forward, what are your thoughts about reliable contact tracing and realities of acceptance of even flu vaccine among vulnerable populations? Do people have thoughts about strategies to promote in a respectful and mindful way?
Hi. I hesitate to answer, but because it's very, very, very tough. It particularly around the vaccine situation, and the conversation continues. We were discussing in our most recent board meeting as the NAACP, and the legacy of Tuskegee and so forth is strong and hard, because and smallpox, as Paulette was saying, there are all the ways that that the history does not in any way encourage folks to engage, and yet this acknowledgement that without those trials, then there will be a gap in data around effectiveness. So it just remains a paradox that's pretty hard to overcome. So just to acknowledge that it's a good question and not at all one that we have found answers to, reality being.
Yeah, thank you.
I can add to that a little bit, to what Jackie shared, is that, you know, speaking from my work at Mary's Center, one of the things that has really impacted the Latinx community in DC, particularly the undocumented community, are public charge rules. People are very concerned that if they access public benefits, including Medicaid or including safety net benefits in DC that provide health insurance, or that if they get free care from a federally qualified health center like Mary's Center, that somehow that's going to negatively impact their ability to become US citizens in the future, which is exactly what the Trump administration is trying to do. And it does discourage people from seeking healthcare and getting vaccinated and getting regular preventative care and, you know, getting all kinds of other benefits that they need to be healthy and for their children to be healthy. So it's really alarming. And so, I mean, I guess the best solution for that is really regime change. So hopefully everybody will vote. It's the best answer I've got right now. It's very alarming though, and very concerning for our patient population.
I think it goes beyond regime change and goes into actually not only how we recognize science, but science and science education, because traditionally we have based a system on a Eurocentric white stream system of science and education. And we have to get beyond that. We have to recognize not only other ways of knowing and doing, but that there are histories and knowledges that are much older than the history that we put so much stock in, as well as the science that, you know, because the science that we have, granted it's new and it's not the worst thing in the world, where I'm not trying to discredit it or throw it out, but it is only 525 years away from thinking the world was flat. So we have to quit building on dead white men's knowledge and actually expand science education and be willing to recognize other indigenous knowledges, because place matters. Place-based knowledges have information that goes beyond this hubris of science, and that one size fits all, and that everything is going to be solvable with the same methods. And the reality is that, you know, we have to diversify. That means including diverse thinking and diverse knowing, diverse peoples and ways of knowing and doing things. This is more inclusive. It's going to create answers to problems that people haven't even really been thinking of, because we've been marginalizing so many people.
Absolutely. Thank you. And what comes to mind for me too in hearing Jackie, Liz, and Paulette speak on this is the power of messengers in the community, and the power of women like yourselves who are out there, you know, speaking about public health and being a trusted resource. So I think that definitely is what we're going to need more and more of in the upcoming months. So with that, I want to turn it back over to Norma to close out. I see more questions are coming in, which is very exciting. So we will follow up with folks and answer those questions via email as much as we can. Thank you so much for your contributions today. We are so honored to have had you here. Norma.
Okay, thank you, Condra, for helping. And yes, we'll try to collate all your questions and share them in the coming days. So, well, again, this has been a truly fantastic discussion. We look forward to continuing the conversation in the near future. I do encourage folks to follow us on social media to receive notifications about any of our upcoming events. So once again, thank you, speakers, very much for your time. It has been a privilege to be your moderator this afternoon. I also want to thank the NCDMPH staff for helping to bring this webinar to fruition. And thanks to you, our listeners, for joining us today. This concludes our webinar.